idea of potentially how patients can be tailored, because as we all know, the stroke patient group is basically not a homogeneous group where everybody takes the same course of recovery with the same lesions, but they are quite heterogeneous, the patients. So just let me move forward. This is what I have to disclose. And as you can see here, you know, I mean, although it's one disease we are talking about, but the levels are quite different. And I brought you one set of data. One is from Casistiniar and one from our own lab, where you easily can see that even if the patients start at the same level here, for example, this group or this group, then part of them, they develop quite differently from other patients. Like if you look here, these few patients, they don't recover over time much, but the others here, they recover to a decent level. And as you can see here, there's basically in all starting points, you see a kind of distribution of recovery in individual patients. So for sure there are a lot of factors which play a role for this. It starts with where's the stroke, where's the lesion, is it a small subcortical lesion in the capsule, or is it rather a media hemispheric stroke? So there are a lot of factors which might influence it, and then it's also a question of the neuroplastic capabilities, what do the individual have in interaction with all the rehabilitative treatments. And in the end, we have to go from a point that we try to figure out as many as of these factors which might be relevant for recovery and use them on an individual level to design the best possible intervention for the single patient. So first question is for sure, can we predict these outcomes of the patients? And again, Casistiniar's group developed first algorithms, so-called PrEP algorithm, where they used some behavioral data, a certain motor score, and they added to this information about the corticospinal tract by using transcranial magnetic stimulation, where you nicely, directly can measure basically from the motor cortex to your effector, the muscle, and you read out the motor evoked potential and use the size of it as one of the predicting factors. And then they used also structural imaging. And how function this algorithm? So if the patients have a relatively good score here, they kind of recover relatively well. If the score is beyond a certain threshold, then they added TMS, single pulse TMS, and if the patients still have a motor evoked potential, you can simulate it, then still they recover relatively well. If the motor evoked potential is absent, then they use basically structural imaging, and then depending of the damage to the corticospinal tract, there was a further differentiation between the groups. So where the corticospinal tract was significantly disturbed, these patients didn't show much of an improvement. And if you look a little bit in a more global sense with several data from this group, so they define something which they call proportional recovery. So this indicates at the end, relatively simple, at least for a certain group of patients, especially the one who have relatively intact ipsilesional corticospinal tract, is that depending on the initial impairment, usually, naturally, this group of patients develops or recovers 70% of the maximum possible which could happen. And one idea is that it could reflect basically the, let's say, spontaneous neurobiological process of recovery. However, you see also patients who do not fit into this concept. And in one of the studies, they kind of try to associate basically the therapy dose, if this matters on this prediction, and it did not matter in this study. However, the kind of dosage was really small. So, but if you look on this, it indicates that the best way to go and to get bigger magnitudes of improvement, I guess we have to stratify patients in certain groups for certain treatments. And I give you a very simple example here. This is from our outpatient clinic, where we looked for basically chronic stroke patients and tried to suggest for these patients patient-tailored treatments. And as you can see here, this is basically over 8 years, the data from the patients. You see also the distribution of the patients who come to such an outpatient clinic is more in the severely to moderate impaired patients. This is the Vogel-Meyer scale here is full points, and this is basically 0 points. And depending on with which function they come for the upper extremity, then you have to decide what treatment you can deliver to them. And for example, if they are Vogelmeier above 40, let's say 45, then they can very well do the forced use or constraint-induced movement treatment. However, a patient who is at this level will not be able to perform this intervention. And for these patients we use, they are an orthosis-based therapy which have to open the hand and allowed them to train a lot, so they had to train then over every day for an hour at home. Or the more impaired, they need assisted systems which take away the weight and allows them to train. And I want to show you there one small set of data. So these were all chronic patients. They were with the Vogelmeier score between 20 and 40, so relatively impaired. They had very limited dorsal extension and almost no extension of the fingers. And so the idea was to help with this orthosis to open the hand and then they can start to train. These patients were stable, so we had even a baseline evaluation weeks before they entered the study, and that they didn't show any improvement from the baseline to the pre-intervention. And then we trained them to use this device, and then they went home and basically trained at home. And as you can see, although these patients before were stable for all these measures, if they train intensively, if they have the specific treatment where they can train intensively, then you see an improvement over time. And after 3 months follow-up, they gained on average at least 8 points on the Vogelmeier score. That doesn't mean that they can do everything now, but 8 points, this allows them potentially later on to enter another group here for treatment. Okay, so in the last now part of the talk, I would like to discuss you some ideas about non-invasive brain stimulation. It entered now around 10 years, the scene of neurorehabilitation, motor neurorehabilitation. But we are at the edge where it looks like we have to think newly a bit about it, because how we used it so far, and this is kind of a strategy, basically we give for all patients the same type of treatment. So you enhance the activity, for example, of the primary motor cortex in the lesioned hemisphere. But it had promising results, and I'll show you in a second, but the results are relatively heterogeneous, and they are non-responders and responders. And because of that, maybe the effect magnitude is not that big. The concept behind it was good, was based on animal data, and there was also nice physiological data. However, we are a little bit at the limits. And I brought you here or examples of meta-analysis, and if you just briefly look on this, you can easily see that some studies had relatively decent effect sizes, and some studies they basically had almost no effect. So in general, the effect sizes are around 10 to 60%. So, well, actually, it's in the range of aspirin. It's not that bad, with 80% relatively risk reduction. However, still, this has not this huge impact on daily life of the patient, which we would like to have, and for sure there are responders. So there will be different means of address this issue of stratifying patients in different groups, and I want to give you one glance of one part of it, which is based on basically neuroimaging, of structural neuroimaging. However, you can imagine also other ways, or at the end we will have a kind of a multimodal battery which we have to use to stratify the patient, but I want to give you a short glance on one idea in this regard. So now, by using modern neuroimaging, MRI-based neuroimaging techniques, we basically can monitor, if you want, in vivo structural integrity. Most of the work is by diffusion tensor imaging, and then you can read out factors which are associated with structural integrity or structural connectivity between certain areas or in certain tracts. So for sure the most explored is the corticospinal tract, and it's also obvious that if the corticospinal tract is relevantly disturbed, so it is associated with basically with residual motor function. So this is what we all know also from the, let's say, clinical daily life, what you see if you see your stroke patients. However, this technique allows also to not only look for the corticospinal tract, but also look for tracts which are between cortical areas, which might play in a certain networks. For example, if you think about a motor network, so you have the secondary and primary motor areas, like the ventral premotor cortex, dorsal premotor cortex, or parietal areas, and for sure they're interacting these areas, especially in patients, in the flow, in the course of recovery. And for sure, you can also track then alternative corticofugal tracts, like for example, cerebellum to motor cortex, or even between both hemispheres. So there's a tool we have at hand which we can use in vivo, which we can use in the patients, and try to figure out if it might help us to stratify the patients in certain groups of groups of treatment and groups of expected outcome, if you want, from the treatment. And there are first attempts made, and so this is a work from Robert Lindenberg and colleagues. And what they basically did, they used 5 days of bihemispheric nodal TDCS. So basically, the lesioned hemisphere was upregulated with the nodal TDCS and the non-lesion downregulated. And they looked for the effects of this stimulation and associated it with the structural integrity of the corticospinal tract in the lesioned hemisphere. And as you can see here, so these are the changes of the Wolf motor function. This they used as their outcome measure. Everything in this direction is basically improvement, everything or here is no improvement, and here you see basically the FA as a surrogate marker for structural integrity of the corticospinal tract. And it's a small study, however, you can see there that the patients who had relatively spared, relatively well intact corticospinal tract, these patients improved much better from this type of treatment than the patients who had a significant lesion in the corticospinal tract. And maybe later on we might even get a bit more in details, because these methods, they offer also that you look for parts of the corticospinal tract in the internal capsule which origins from, for example, the ventral premotor, primary motor, and PMD, and you can associate this with motor function. So here in this study performed with Nick Ward together, the strongest association with residual motor function were the tracts which origin from primary motor cortex or premotor cortex. So if you look on these single tracts, for sure you ask yourself, is there an interaction? So does it at some point matter if the corticospinal tract is impaired more or less for the relevance of the interaction between, let's say, the structural connectivity between the secondary motor area and the primary motor area? Or are they totally independent? Or everything is basically driven by the corticospinal tract damage? So in this question, we addressed in a study where we used 25 chronic stroke patients with a relatively heterogeneous lesion profile and a functional profile, and we defined a network from primary motor, PMV, and PPC. And we looked in this if there's additional to the prediction of the corticospinal tract, if other connections might have an association with the residual motor function. And as you can see easily here, as expected from different studies, as expected from clinical work, the corticospinal tract for sure is strongly associated with residual motor function. However, on top of this, independent of this, also the ventral premotor or primary motor cortex interaction seems to be associated additionally with recovered motor function. And then for sure you can define the PMV as a new target for brain stimulation, and I want to show you very briefly a pilot data which we acquired now. So we combine 3 days of training with simulation of the PMV, and as you can see, is the patient trained more effective with PMV stimulation, and this effect is on follow-up also there. But the most interesting thing of this was that a patient who had the most impaired corticospinal tract were the one who improved the most with the stimulation. So if you take this together, then you could imagine there is maybe an interaction between the magnitude, the degree of corticospinal tract lesion, and the relevance for interactions between secondary and primary motor areas. This we addressed in another study. This question was done with Professor Yan-Hee Kim in Seoul together. We had 53 stroke patients, again, relatively heterogeneous lesion and function profile. And we used basically the same network, and the only difference in this evaluation was that the patients were stratified in 4 groups due to the degree of damage to the corticospinal tract in the lesioned hemisphere. So, what came out in this study? So, just to lead you through it, so yellow means the corticospinal tract in the lesioned hemisphere is not much impaired, and pink or pinkish and lila it's much more impaired. And here on the x-axis you see the structural integrity between the ventral premotor cortex and primary motor cortex. This is relatively well perceived structural integrity, relatively more damage, and motor function you see here worse and better. And if you look on the patients who have a very mild lesion of the corticospinal tract, there you can easily see that the structural integrity between this network between the primary motor cortex and ventral premotor cortex has absolutely no role for residual motor function. However, if you look on the patients who have a significant damage to the corticospinal tract, for them it mattered whether they have relatively good structural integrity between these areas or not for residual motor function. So, and if you take this forward, then you can basically make a model of patient tailoring in a way which has to be tested for sure, but you can create this idea that you develop based on the data I showed you also before from other groups, is that if the CST is mildly lesioned, then the chance that this patient respond relevantly to a combination of training with M1 brain stimulation is good, I think. And you would expect a rather limited answer to ventral motor stimulation. However, if you think about these patients here in pink, for them you would predict that we know that they don't respond very well to primary motor cortex stimulation, and we would predict that they might much better respond to PMB.